Hi, good evening. I think we need to start. My name is Leo Jacqueline Laura. I'm the BBY Leads Officer and an SRH Ambassador. I will be your moderator today. Our speaker today is Nurse Linda. She's a registered nurse and a member of Kenya Student Novice Nurses. She's also a founder of Med Demystified. She'll be taking us through our session today, pregnancy. And to our participants, you are the leaders and ambassadors to the community. In the next 1 hour to 30 minutes, you will learn more the importance of the week by week pregnancy, what to expect on those stages, and maybe adequate it through all the stages. Let's get an inside secret from somebody who understands more about week by week pregnancy. Please let's welcome our nurse, Linda Gitonga. Linda, your floor is yours. Thank you, guys.
Hi, good evening, everybody. My name is Nurse Linda. I'm a registered nurse here in Kenya, and I am a medical educator. Currently, I'm working at Nyahururu Medical Training College as a lecturer, which is something I really love doing. And so I'm so delighted to be here with you. I know my video quality isn't the best. Kenya Power today decided to do its thing. So niko kwa giza, I'm trying to use my spotlight. So kindly bear with me. I hope you can all hear me. Someone to kindly let me know if I'm clear.
Yes, you're clear.
Thank you. Thank you so much. So I'll share my screen so that we go directly into the discussion. And as the moderator has just said, we are discussing the week by week pregnancy today. And I welcome you all to the discussion. Feel free to converse in the chat box, and I'll be delighted to be able to answer all your questions. So as we begin, I would like us to understand the objectives of the discussion today. And first and foremost, we need to understand the development of the fetus from conception until birth. From that point where we have the ovum and the sperm meeting, how is this development ongoing from just 2 small cells up to the formation of a full-grown baby? And secondly, we need to understand the changes that occur in the woman every week of the pregnancy. As this fetus is growing inside the woman, we have various changes taking place in her body. So what are these changes? And these are changes that predispose this woman to a number of problems. So we need to understand these problems and how do we solve them? We are the ones who are with these women. Sometimes we are the ones. And so as we experience all these problems, we need to be able to know how do we maneuver them? How do we advise them? And then we need to also understand the danger signs of pregnancy. These are the various things that make this woman be at a risk. So how do we identify them? And then finally, at each stage of pregnancy, we are going to be able to develop a to-do list. What is a woman supposed to do at each of these stages of the pregnancy? So that is basically what I have lined up for us. I hope we are going to understand and have an interactive session. We are going to discuss the pregnancy in 3 stages, which are 3 trimesters. The first trimester, which starts from the first week to 12 weeks. We have the second trimester, 13 to 27 weeks. That trimester, 28 to 40 weeks. So just to make it easier for us to understand, we are going to break it down in those 3 phases. So at each phase, we are then going to look at the fetal development, the maternal changes, the problems that she might experience and possible solutions, the danger signs, and then develop a to-do list of each of the stages. And with that, we have a diagram here showing us fetal development. I would like to invite one of you participants to briefly tell us what you can see from this image. Anybody to tell us briefly what you can identify?
I can see a head.
Mm-hmm.
Their arms and feet. And we have the cord, the umbilicus.
That's lovely. Thank you, Teresa. Another opinion?
I can see the head, and then from the beginning, the head is small, smaller, small, and then it's growing to be bigger that way.
Correct. Thank you, Alice. So from the very first diagram, you can see where my cursor is. You can see a very tiny little human, and they are developing through all these stages, becoming bigger until they become a full-grown baby. So that is what we are going to be discussing. How is this small little thing growing from this tiny human that you can see right here throughout all these stages? And this is basically just an enhancement of that image. You can see at 3 weeks how the fetus looks like. At 4 weeks, we have 5 weeks. It's just enlarging. And you can see, like in this first image here, you can't clearly identify where we have the head, where are the limbs, as compared to at 38 weeks, where you can clearly see a head and you can see the limbs of this fetus. And so we need to really understand what is going on in the uterus throughout this process. So to begin with, we have the first trimester, which is 1 to 12 weeks. And for the fetal development, the first trimester begins immediately at conception, when we have the sperm and the ovum fusing, and then we have fertilization taking place. And this one occurs in the fallopian tube. I believe that you have looked at the basic anatomy of the female reproductive system. You have seen where the fallopian tubes are. So that is where the fertilization is taking place. And we have the formation of a zygote. It will transform to different names, and we only call it a baby once it has been born. So from a zygote, it travels along the fallopian tubes all the way to the uterus. And as it is traveling, it is undergoing a lot of division. Remember, we started from just 2 cells. That is the ovum and the sperm. They fused together, and it has to undergo a lot of division. We have the mutation of the chromosomes, a lot of changes taking place within those cells until we have the formation of the embryo, which happens by around day 4. And at week 2, we have implantation taking place. So implantation is the attachment of this embryo into the muscles or into the lining of the uterus. Implantation is taking place at the uterus, and that is where this fetus will grow. So at week 2 is when we have that attachment of the embryo to the uterus. And we have the production of HCG, that is the human chorionic gonadotropin hormone, which is produced by some of these cells. Now, this HCG is the one that we test using the urine test. And you were told that at around day 8, you can test. And this is because we have HCG being produced by the cells at around week 2, and it can be detected in urine. The HCG maintains pregnancy, and it will, of course, prevent menstruation. Now, menstruation occurs when fertilization has not taken place. And for menstruation not to occur, then we have something that is preventing the body from having another ovulation when we have a fertilization already taking place. So we need mechanisms for the body to be able to retain this pregnancy, for the pregnancy to grow up to term. Then at week 3 to 4, the embryo is continuously getting enlarged, and some of the body systems will begin to form. The heart, for example, begins to be formed, a very small heart, and it begins to beat. and at around the 16, the neural tube is formed, and this is the tube that later becomes the brain and the spine, sorry. And at around the same time, we have a layer of skin developing, and then the limbs, that is miguu to mikono, they start budding. They start growing like small nodules, and we will see them developing up to full-grown limbs. By week 4 to week 8, we have more rapid cell division, and more body systems are formed, and they continue to develop. So as the fetus is growing, we have the different body systems. The respiratory system, we have the lungs, we have the bronchioles, we have the gastrointestinal system, that is the stomach. You will have the cardiovascular system, that is the heart, the blood vessels. All those organs develop slowly, and this is happening in the first trimester. At around 6 weeks, the heart has taken shape and it is beating, and now we can hear the heart sounds through an ultrasound. When you go for an ultrasound at around 6 weeks, then we can see the heart beating through the ultrasound. At week 9 to 12, the heart is fully formed at this stage. And when you look at the fetus through an ultrasound, it is usually making small jerky movements. The woman will not feel the movements at this stage because it is very small. But when you see that through an imaging, which is an ultrasound, then you're able to appreciate those jerky movements. We have the bones of the face being formed, the eyelids are closed, the placenta develops rapidly. Now, the placenta is that organ that attaches the fetus and the mother, and it acts as the nourishment center. It is that organ that supplies the fetus with all it needs, that is from the mother, and also transfers the waste products from the fetus back to the mother. So it is the nourishment center, and it develops along the pregnancy. And by the end of this first trimester, most of the body organs are well developed. What is remaining is for them to mature. They are just in situ. Like, for example, the heart is there, not fully developed. The lungs have begun being developed, but they're not fully mature. So we'll have the maturation of these body organs as the pregnancy continues. And now, as this fetus is growing inside the woman, we expect to find a number of changes taking place in the woman. So number one, we will have a missed menstruation. And fortunately or unfortunately, that is the first sign that most women notice for them to realize that they're pregnant. And remember, now they're missing a period a month later, meaning that by the time they're recognizing they're expectant is almost a month into the pregnancy. So they miss their period. Number two, they will have breast tenderness, and that is being related to the hormones of pregnancy. A pregnancy, we have...
Please, kindly, we are not able to see your slide. Can you check on your slide, please? We are just on slide 1. The slides are not moving.
What happened? Let me check that, I'm sorry. Can you see them now?
Yes, we are only seeing the first slide, the one with the first trimester, but the other slide, your slide is not moving.
Oh, I don't know what happened. We were at maternal changes. Can you see that now?
Yes, we are seeing maternal changes, but you see, you have gone ahead, all that through, you are just seeing one slide.
Oh, sorry, I didn't notice that. Don't worry, I'll share the slides after the lesson so that you'll be able to look at what we have gone through. That in order?
Yes, that's okay.
Sorry, we were trying to appreciate the changes that take place in this woman as the fetus is growing inside her. And the first one you talked about was the missed menstruation. We cannot have a menstruation or the monthly periods while a woman is expectant. And number two, we said we have breast tenderness, which is being related to the pregnancy hormones. For a pregnancy to be sustained, we have hormones like the progesterone, which sustains that pregnancy. And some of these hormones will affect other body tissues, that is, for example, the breast. We have the breast enlarging. Remember, the body needs to prepare itself for lactation, that is for breastfeeding at the end of the pregnancy. So along the pregnancy, the breasts are adapting or changing so that they are able to sustain the breastfeeding, and so we will have breast enlarging. We can have deep white discharge, that is vaginally. And now, when she is expectant, we have like a mucus that closes up the cervix to contain the products of conception, that is to contain whatever is in the uterus. So sometimes she will have that thick white discharge, which is very normal, as long as it is not foul smelling, she's not itching, and it is just white discharge. Any other color, we are going to classify that under some of the problems that she's likely to have, and we are going to talk about what she can possibly do if she has a discharge which is not white and it is probably foul smelling. And now these are the possible problems that she's likely to have, and we are going to try and look at some of the solutions that we can give to this woman. The first one is vaginal spotting or bleeding, and spotting is very normal during the implantation. When implantation is taking place, it's like the embryo is burrowing itself inside the uterus, like in a chamber. And when that is happening, we are likely to have very minimal spotting, and that is fine. But in case you have bleeding at any stage of pregnancy, then that is a danger sign and you need to be checked up. So spotting is okay, but bleeding then becomes a danger sign. Secondly, we have talked about the breast tenderness, which we have said is attributed to by the pregnancy hormones. And one of the things that the woman can do is going up a bra size. So whichever size of bra she was using, she can try and get a bigger size of that bra so that she's comfortable. Remember, we've talked about the breast enlarging. And so most likely she's going to outgrow the normal size of the bra that she was using. So for her comfort, we advise them to just go up a bra size. She's likely to have constipation, and this is related to the high levels of progesterone being produced, and this progesterone decreases the contraction of the muscles that move food along the intestines, and therefore she will have constipation. And one of the ways to reduce constipation is encouraging the woman to eat more fiber, that is, eat a lot of vegetables, eat the whole grain meals, have extra fluid that will increase the motility of food throughout the intestines. And then she also needs to do tolerable physical exercises to also facilitate in the movement of food along the intestines. She can have discharge. We've talked about the thick white discharge, which we have said is normal. If it is in excess, she can put on panty liners to prevent herself from being swelled every other time. And now, if the discharge is foul smelling, it has a fishy smell, a funny smell. If it is not white, any other color, maybe it is creamish, it has turned brown, and maybe she could be itching as well, complaining of an irritation when she passes urine, maybe pain during sexual intercourse, then she needs to be able to seek medical attention because that is a sign of an infection. This woman can also experience fatigue, and she needs to get enough rest and continue taking her supplements. Normally, when she starts her ANC clinics, that is antenatal clinics, they are put on supplements. So she needs to be taking up more of those supplements so that then her blood level is boosted, and that will prevent or reduce the fatigue that she's having. Enough rest would also do her good. Most other women will also have food cravings, which is very normal, only food cravings. Not in the last point, we have the woman craving non-food items. That is dangerous for mother and baby, which we call pica. We've seen women who want to eat stones, women who want to eat, maybe they're looking for metals. That indicates they are lacking something in their body. Food cravings are very okay, but now when it comes to non-food items, that is pica, we need this woman to consult and maybe let's find out why is she having non-food cravings. And so that now if we have anything like a mineral depleted in the body, then we are able to boost that and adjust it to the normal so that she does not crave these non-food items. I hope we are together to this point. the other challenge she might experience is a heartburn. This is also due to the progesterone, which causes the relaxation of the sphincters. We have the sphincters that hold the food content down in the stomach, and that prevents this food content from going back into the esophagus. And so the progesterone relaxes those sphincters. And so any other time, this woman is likely to have a reflux, like the food going back upwards from the stomach, and that will of course give them a heartburn. Remember, in the stomach, we have the hydrochloric acid. So when food gets in the stomach and combines with the hydrochloric acid, then it refluxes back. We will have a reflux of food that has the HCl, and that burns them up, which is a heartburn. And we advise them to take small, frequent meals. And by doing so, we allow the body to digest the little food they have taken, so we do not have any excess food remaining in the stomach. We also advise them not to lie down immediately. When they lie down, we are likely to have a reflux of food back into the esophagus, leading to the heartburn. And then they avoid greasy, acidic foods like spinach. There's the citrus fruit like oranges. We have the lemon. They need to avoid that. And then they elevate the head when they are sleeping. That will also prevent the reflux of the acidic food content back into the esophagus. Next, they experience mood swings. This is very normal in pregnancy, and the best we can do to support them is to give them psychological support. So whenever we are around an expectant woman, let us always want to give them psychological support so that they feel supported. It's not an easy journey. We need to work with them. And so if they find you as the one providing care to them and they are having their mood swings, then we can give a listening ear, maybe take them through counseling if it's in excess. Then they can also have nausea, which is mostly referred to as morning sickness. With this, they can sip water. They can take crunchy snacks, for example, crisps. They can take biscuits. They also need to avoid smelly and fatty foods, those foods that have a very strong odor and it makes them feel nauseated. Fatty foods as well, food with a lot of fats will contribute or will worsen the nausea. And now if the nausea is intolerable or it progresses to vomiting, they need to consult a doctor. With the vomiting, we are having the woman losing a lot of body fluids and electrolytes, which would be of danger to both her health and that of the fetus. So we need to be very careful when she eventually gets to vomiting. If we can't manage nausea, then there's a medical support that they can get to prevent that nausea if it is intolerable. And now, having discussed the fetal development and the changes happening in the woman, we've also talked about the possible problems that they could have and the solutions that we can give to them. What do we require these women to do in the first trimester? What is very important for them to start doing? Number one, which is very important, they need to start antenatal clinic. We have moved from the ancient 4 clinics, and now we are advocating for at least 8 antenatal clinics, which means a woman needs to start her ANC clinics immediately she realizes that she is expectant. And you will sometimes we also advocate for them to go for preconception care. Just start the clinics even before you get expectant. That is when you're planning for a pregnancy. And now if you hadn't planned for the pregnancy, immediately you realize that she is expectant or she realizes that she needs to start up the clinics. They are very essential because you have a professional working with you through the pregnancy journey. You're able to do some tests which are very relevant. You're given the supplements. At least you have someone working with you the journey, and you're able to identify when you have any problems. And as they start their clinics, they will be started on IFAS. IFAS are iron supplements, which are very important for the development of the fetus and to also boost up the blood level of the woman. Relevant tests will be done. For example, we need to know how much, the level of blood, that is the HB level. we need to know, is this woman having any infection? And some of these infections are very dangerous to the fetus. And so it is very important for us to identify these infections very early and they get treated even before the pregnancy progresses. We will have other tests like the HIV test, which is also very important. Sometimes we've had women who have known their status being negative for a very long time, but shock on them, they go for their ANC clinic and they find out that they have a positive status. It isn't the end of life, yes, but then we are able to be more cautious to prevent the transmission of the HIV infection to the unborn fetus. So it is very, very important that we take such precautions. Then she also needs to start her financial planning so that we avoid the last minute stress. The woman is almost in labor, and that is when now she's starting worrying about, where do I get money to get a delivery done? I do not have any insurance cover with me. I didn't register for Linda Mama, and all those issues. She becomes really stressed up. So we need to insist that as soon as she knows that she's expecting a baby, she needs to plan to start making financial plans. We have she needs to break bad habits, for example, drug abuse. If she has been using alcohol, smoking, whatever drugs she has been using, she needs to know that that is dangerous for the growing fetus and she needs to stop those habits. She needs to enrich her nutrition, take a balanced diet for the health of her own body, and so that the fetus is also nourished. Remember, the fetus is being nourished from the mother. So if she's not having adequate nutrition, then whatever the fetus gets is very insufficient, and that will result to us having a very bad outcome of that pregnancy. She needs to start planning for the baby, start getting the the items that baby will need. We do not need to wait up to delivery and then we are running around the market all over. Let her start planning as early as possible, and that also minimizes a lot of stress. You don't have to get a huge amount of money to go for shopping. Instead, it would be easier if you have your 100 shillings, go buy this item today. Tomorrow you've got your 200, you do something small. And at the end of the day, you will have everything that you need for that baby without a lot of stress. We also advise them not to self-medicate. A pregnant woman should never have any drugs over the counter. She always needs to consult, because some of these drugs are contraindicated in pregnancy. We have drugs which contain agents that will affect the growth of the fetus, sometimes giving the baby malformations. The baby is born with problems that were as a result of some of the drugs that she used during pregnancy. So we encourage them not to medicate themselves, always to consult a doctor always. And when they do so, even before the pregnancy shows, they need to always alert whoever is attending to them that they are expectant. We are going to look at the danger signs. That is in the first trimester. What do we look out for? If, for example, this woman is having severe abdominal pain, that is something to alert the woman that everything could not be okay. We do not expect her to be having the severe abdominal pains. There could be signs of maybe a miscarriage, just something that is not normal with the pregnancy. And so anytime she has the very severe abdominal pains, she needs to consult. Anytime she has vaginal bleeding, we've said we can have spotting early in pregnancy during implantation, but if it progresses to vaginal bleeding, then it worries us all. If she has severe dizziness, that will definitely tell us that maybe she's not having enough blood in her system, and then we will need to correct that. So severe dizziness, severe headache, that needs to be checked. I hope we are all together up to that point. Any questions so far before we move on to the second trimester?
Yes, I can see Ezekiel is asking, is it advisable for pregnant mothers to wear bras and panties?
I can't get you clearly.
Ezekiel is asking,
Mhm.
is it advisable for pregnant mothers to wear bras and panties?
Yes, they should. Why wouldn't they wear a bra? We've talked about the breast tenderness, and we've also talked about the breast getting enlarged. If they are enlarging, then the weight of the breast is increasing. And if they leave them hanging, then we will have a strain on the breast tissue. So it is still advisable that they continually wear their bras. About panties, I don't know why we are no longer wearing panties, but I feel it is important, and it will assist even in prevention of infections. As we are walking around, there's a lot of dust going in. If, for example, you're not in a trouser, you're in a dress, you imagine all that dust going up your system. So it's still very advisable for them to continue putting them on. Is there any other question, or we go on?
And then Alice is asking, is the white thick discharge not a healthy problem?
A healthy problem?
Yes, that is what she's asking.
We've said the thick white discharge is a normal change in pregnancy. It only becomes abnormal if it becomes foul smelling, it has a funny smell, if she is itching herself, if she has an irritation when passing urine, or if the discharge has changed color to a different color, maybe a brown discharge or a creamish discharge. But a white discharge is very normal in pregnancy.
But can the discharge be that frequent? I mean, can it be too much and then that frequent? Is it also normal?
Most times it clears as the pregnancy continues. But again, if you feel that the discharge you're having is a disturbance to you, then you can always go for checkup and maybe check whether there was an infection. But if no infection, then we still consider that normal. And one of the ways of managing that, if you have ascertained it is not an infection, then you just need to put on maybe a panty liner, which you change oftenly so that you don't get soaked up in the discharge.
Okay,
I think we can proceed. Then we will answer the other questions later. And we are now in the second trimester. That is from week 13 to week 16. You can see how our fetus is doing. At least we can now appreciate the head. We have the limbs, and we have the placenta, which has also grown in size. And first and foremost, the ovaries and the testes are fully developed in the fetus, and the genitals are formed outside the body. So whether female or male, the particular genital organs have been formed and they are on the body of that fetus. The fetus begins swallowing the amniotic fluid and passes it as urine. So wherever the fetus is it has been surrounded, or it is contained in the embryonic sac. And inside that sac, we have the amniotic fluid. And as it is growing, it starts swallowing the amniotic fluid and it passes urine, which is to tell you that the kidneys have developed and they have begun functioning. And if this fetus is able to swallow inside the uterus, then they are ready for breastfeeding. We have the body being covered by fine hair, which we call lanugo. And the sex of this fetus can be identified on ultrasound by week 15. Those people who appreciate gender reveal, at week 15, you can always get an ultrasound and you know the gender of the baby that you're expecting. The fetal heart can be heard using a fetoscope. Now, if you have gone to an A&C clinic, there is a tool that the midwives will use to place on your abdomen and listen into the fetus. That is what a fetoscope is, and we can hear the fetal heart at 16 weeks. Before then, in first trimester, remember we were only getting the fetal heart through an ultrasound. And at week 17 to 20, the fetus is making more rapid movements. The skin is developing and it is transparent. you can see through the skin. If, for example, you find a baby who is a premature, a baby who has been born before the 40-week gestation is over, you are always able to see the blood vessels under their skin, meaning the skin was not fully developed. And so at week 17 to 10, the skin is transparent. The main airways begin to develop, that is the bronchioles. The fetus can hear sounds, and that is why we will always encourage a couple or a woman to always keep talking to the fetus. They can hear sounds and it creates a bond in between them. The placenta is also well developed, that is to nourish the fetus, and it continues maturing as the pregnancy continues. At week 21 to 27, the organs continually mature, the fetus makes strong kicks, and the woman can actually report the kicking of the fetus. The fingers and toes are fully formed, like you can see in the image right here. And the eyelids open for the first time and the fetus start blinking. That would be beautiful. And now, having seen how we have developed up to week 27, we will have the maternal changes that have taken place or that take place during the second trimester. Number one, the abdomen starts to enlarge as the fetus is growing. In the first trimester, it is difficult to identify an expectant woman because the fetus is not fully grown or fully enlarged to the extent of enlarging the abdomen. So the abdomen starts enlarging at around the second trimester. The woman starts gaining weight. Remember, we have the fetus growing inside her. That's something that was not in her. And as it's growing, it's adding on to her weight. And she can feel the baby moving by about 16 weeks. The uterus can be felt from below the navel. When you palpate or you try to massage her abdomen, you can feel the uterus that has grown out of the pelvis, and a dark line running from the belly button to the pubic bone is present. We have stretch marks on the belly and the breast. Remember, her skin is enlarging to accommodate the growing fetus. And as that happens, the stretch marks are definite to happen, if not in all women. The breast may start to leak a little pre-milk. Remember, we said the breasts are also preparing for breastfeeding. And so she might start having the breast excreting milk. And now with all those changes that are happening in the growing fetus, we are also likely to have a few of these problems. And these are some of the solutions that we can give. I just picked out the most common problems I have encountered women presenting with, because the problems are many and they are unique to different people. So it's not always that every woman will experience heartburn, but now the majority I have encountered with that is a common problem they have. And with the second trimester, they are likely to have frequent urination. Remember, the fetus is growing and the position of the uterus is just close to the bladder. And so as this fetus is growing, it is applying pressure on the bladder. And the bladder that could hold on a large amount of urine now cannot sustain that amount of urine. And so with a small filling of the bladder, she wants to void. And how she can manage that is by avoiding too much fluids in the evening while she's just about to go and sleep. Because now if she continues taking fluids in the evening, she will need to continue voiding, and that will affect her sleep pattern. She will keep waking up at night. In the morning, she wakes up with a lot of fatigue because she was not able to sleep. So it's very normal, but then we can look out for ways to make her more comfortable and make sure that she's able to sleep enough. We do not restrict fluids during the day because the fluids are very important. We encourage them to take in more fluids. She can experience back pain. Remember, we have the progesterone that causes the relaxation of most of the muscles. So we will have relaxation of the back muscles. We have relaxation of the pelvic muscles as they prepare to give way during delivery. And the way to manage that, she can lie down, take a rest. She can get frequent massages on the back. she can apply a heating pad or hot water bottle to the area. With a heating pad, she just needs to get a warm bathing cloth, soak it in hot water, and just pad it on the back. That will ease the discomfort and the pain. She could also experience heartburn. And in the second trimester, remember the fetus is also growing upwards. We are having the baby bump coming up. And as that is happening, we have the compression of the stomach. So in layman's language, the stomach becomes smaller, and we will have an ease of the contents in the stomach going up very easily because the fetus is really compressing on the stomach, and the incidences of heartburn go higher. And just like we said in first trimester, she is advised not to sleep immediately after eating. Let her allow time for digestion to take place so that food content in the stomach is cleared out. She needs to elevate the head of her bed and also avoid acidic foods. She could experience drying skin due to the stretching. As the skin overstretches, it becomes dry. So she needs to moisturize the skin with oil. And then she could also experience lack of sleep, especially when she's having frequent urination at night. Sometimes the baby bump is really pressing on her blood vessels, on her nerves. She feels tired. She can use pillows just to elevate that baby bump so that she is more relaxed and flexible, and comfortable so that she can be able to sleep. And now what does this woman need to do at the second trimester in preparation for the birth of the baby? She needs to continue ANC visits. We said she starts ANC visits as soon as she recognizes that she's expectant, and she needs to continue with them. They need to follow the guidelines that have been given. You've seen your midwife or your gyne, and they have advised you to go maybe for a clinic every other month, maybe after 2 months. We need to advise women to always stick to that so that we have frequent checkup and we monitor the pregnancy from the very first day up to the delivery. She needs to get her tetanus vaccine. We have a schedule for the tetanus vaccine. The tetanus vaccine is important in protecting the woman and the growing fetus. And we will follow the national schedule that we have. So if, for example, it is in the first pregnancy, she gets her first tetanus vaccine, which is given in the second trimester. Remember, we said in the first trimester, we are the fetus is really growing. And so we avoid a lot of medication that could affect the development of the fetus. And so most of these vaccines will be reserved to be used from the second trimester. So if it's the first pregnancy, she will get her first tetanus vaccine, and a week later, she gets her second tetanus vaccine. If it's a second pregnancy, in the second trimester, she will get a third tetanus vaccine, and it continues with the subsequent pregnancies. Of importance is to note that we are giving the tetanus vaccine in the second trimester of pregnancy. She needs to continue the supplementation. The IFAS that was started in the first trimester, they are very important. We continue with the supplementation all along the pregnancy. She needs to have a birth plan, and a birth plan will include things like, is she financially planned? How is she planning herself financially? Does she have an insurance? Who will be her birth partner? Who will escort her to delivery? Where will she deliver? How will she get from home to the facility? Basically, look at all the logistics around the delivery of the baby. Where will we take care of this baby after delivery? Do we have enough supplies for the baby? Basically, just plan herself so that she's very ready for the birth of the baby. And then she also needs to do pelvic floor exercises. She needs to maybe take a walk briskly, sometimes jog a bit if she can, just sustainable exercises to make sure that she's flexible enough and her pelvis is giving way enough for the delivery to take place. We are going to look at the danger signs that she needs to look out for during the second trimester. And the first one is the swelling of the face, the hands, and the feet, which is a sign of increased blood pressure, hypertension in pregnancy. which we call preeclampsia, and it could progress to eclampsia. And now with the swelling of the face, hands, and feet, she needs to consult because that indicates that her blood pressures are taking up a higher note. She could experience severe headache, just as in the first trimester. Severe headaches, sometimes, okay, headaches could be normal. Maybe she's had a tiresome day, she's been under the heat, under the solar for a long while, she's having a headache, which when maybe she rests disappears. But in this case, she's having a headache that doesn't disappear with the normal resting, and so she will need to be checked up. If she has blurring of vision, she's not able to see clearly, that also indicates increased blood pressures. And of course, if she experiences bleeding. Bleeding in any stage of pregnancy is abnormal, and it's something that we should never ignore. Do we have any questions? Any questions concerning the second trimester? Are we understanding how the stages are flowing and whatever is happening?
Yes.
Thank you, Terry. All right. If you don't have any questions, we are going to move on to the third trimester. And this is the final trimester of the pregnancy, the third phase, which begins at week 28 to 32. From the diagram again, if you compare this with what we had when the pregnancy was beginning, this is quite a milestone. You can see the baby, the fetus is already sucking the thumb. It's a full-grown baby at the end of this third trimester. And in this trimester, the fetus is weighing roughly 1 kg, that is at 28 weeks. They have a sucking reflex, like you can see this one already with their thumb in the mouth, and that has prepared them for breastfeeding. And the skin looks much smoother. The hair begins to disappear. Remember, we talked about the hair, the lanugo in the second trimester that was forming on the fetus's skin. At this point, it disappears, and the fetus gains weight rapidly. By week 33 to 36, most of the organs are fully mature, except for the lungs and the skin. At around week 37 to 40, the fetus head is usually positioned down in the pelvis. As you can see in this image, it is ready for birth. Unless in an abnormal situation where the fetus has not turned and we have an abnormal position. So for the normal pregnancy, at that stage, the fetus head will be turned down into the pelvis. The bones and the muscles are ready for the outside world. That is the fetus. They are basically ready for birth anytime in between the 37 and 40 weeks. The skin has fully matured and now it appears pinkish, just the normal color that you see on a newborn baby, and the fetus is ready for birth. And in the third trimester, we have the following maternal changes taking place, in addition to whatever we have discussed in the first and the second trimester. And number one, she can feel the fetus above the navel. She will still continue feeling the movements of the fetus. The stretch marks would continue becoming bigger and more visible for the reason of the stretching of the skin to allow for the growth of the fetus. The cervix starts to thin out and opening ready for labor. Initially, at the beginning of the pregnancy, the cervix was very thick to protect whatever is inside the uterus so that we do not have a miscarriage happening. But now at this stage, towards the end of the pregnancy, the woman's body starts preparing for the birth of the fetus. And one of those things is that the cervix will start becoming thinner and it starts opening so that at the end of the period, it will allow for the birth of the fetus. Breathing is now more comfortable. I didn't mention that in the second and almost towards the end of the third trimester, the woman experiences difficulty in breathing for the reason that the fetus has grown upwards and it presses on the lungs. And so the room for lung expansion becomes less and she has difficulty in breathing. But towards the end of the third trimester, we have the fetus engaging or getting inside the pelvic bone and it descends a bit. So it gives more room for the lungs to expand, and she becomes more comfortable in breathing. She could also experience a number of problems and solutions. Some of them we have already discussed. She still can experience the heartburn, the breathlessness, and for breathlessness, she can elevate the head of bed. With frequent passing of urine, we've said she avoids taking in a lot of fluids in the evening. The backache, we've talked about her taking a rest, doing massages, padding the back, maybe doing regular exercises. And those are just some of the problems that she could experience. And I'm sure by now we are able to handle or advise them when they are having some of these common challenges. These are some of the things that she needs to look out for in the third trimester. Number one is high blood pressure. Every time the woman goes for antenatal clinics, the body vital signs are measured. That is the blood pressure, the respiratory rate, and that is why it is very important for an expectant woman to always take or go and attend her clinics so that we monitor the vital signs of the body. So in case she has high blood pressure in pregnancy, that is a danger sign and she needs follow-up or acute management. Drainage of liquor. Liquor is the amniotic fluid. So at any point we have the membranes breaking, what people say maji imepasuka. At that point, then that becomes a danger sign because that is one of the signs of labor setting in. And when that happens, if for example, the pregnancy was not at term, then it poses the fetus to an infection. And so anytime we have the membranes breaking and the liquor draining, then this woman needs to take an action. Number three, if she has reduced or absent fetal movements. With time, once the fetus has started making fetal movements, she identifies the patterns. If you ask a pregnant woman how often the fetus kicks, they will tell you. And so anytime they realize that the fetus is not making fetal movements, she can't feel the movements anymore, or the frequency of the movements and the strength of those movements have reduced, then it is something that needs to alert her that probably we could have a problem and it needs to be checked. Severe headaches, which will be attributed to high blood pressure. Convulsions as well. Now, convulsions in pregnancy is what we call eclampsia, and it happens as a complication of high blood pressure, which is preeclampsia. So when it gets to convulsions, then it becomes a very delicate state for this expectant woman. And next, we have difficulty in breathing. Difficulty, now besides the normal one due maybe to the posture that she's having, she has tried changing her posture, but she's still maybe gasping for air, then she needs to be checked. We have the few things or a number of things that she needs to do in the third trimester. Number one, prepare a birth pack. A birth pack will contain all the things that she and the baby will need at birth, and she needs to always carry it around with her. Labor can happen, can start anywhere, and so she needs to always be fully prepared. Yeah, labor is setting and now she's trying to pack her bags. Let her pack early enough so that at any point she has the signs of labor setting in, she's able to quickly gather herself and present herself to a health facility. She needs to be prepared for delivery anytime, including financially. Remember, we started planning for this baby at conception. And so has the preparation been concluded by the time she's getting in labor? What has not been summed up? Are we able to do that in the third trimester before we get to the last weeks where we can have labor at any time? It's not always that labor will get to, the pregnancy will get to 40 weeks. Sometimes it gets at 36 weeks and still the baby can survive. So that is why we are insisting on this woman being prepared from as early as she realizes that she's expectant. Let her prepare for delivery. And she needs to watch for true signs of labor. We have true and false signs of labor. And for the true labor, she will have contractions, and the contractions will happen at regular intervals, and they get closer together with time. So this woman will be able to tell you, I'm having a contraction after every 5 minutes. another 5 minutes, she has another contraction. And as time progresses, the contractions are coming in closer. Maybe initially a contraction was coming after an hour. After some time, the contractions are coming in after 45 minutes. So it is progressive in nature. Unlike for the forced labor, where contractions are irregular and they do not get close together. So she cannot give you any pattern of the contractions happening. They're just coming on and off. There is no regularity in them, and they probably could be getting apart from each other. For the true labor, we have said they come closer. If they were happening after 1 hour, they are now happening after 45 minutes. They are now happening after 30 minutes. But for the forced labor, the contractions will not get closer to each other. Maybe the first one is after 30 minutes, the next one after 1 hour, the next one again 45 minutes. So it is very irregular. Number two, the true labor, the contractions do not disappear despite her moving or changing position. So if, for example, she was seated and she has contractions, maybe decides to stand up and walk a little bit, that will not ease or make the contractions disappear in true labor. But in forced labor, if she decides to walk, maybe take a rest, change posture, if she was standing, she sits down, then the contractions will reduce. So women need to be able to identify when they are having true contractions, that is true labor, so that then they are able to seek care in a health facility. And having looked at that, we are going to see the signs of labor. Which are these signs of true labor? And number one, we have contractions that are regular and increase in intensity, and they radiate to the back. So this is pain that, as I have said, is regular. You can give in a happen after how long? It increases in intensity. So it will start as mild pain, continues to moderate pain, and then it intensifies. So the pain increases with time, and that pain radiates to the back. Normally, it will start at the lower abdomen, and the pain goes all the way to the back. So that is the first sign of labor that every woman needs to know. Number two, they will have what we call show, and show is a bloody mucoid vaginal discharge. They will have a discharge, but in the discharge, you can see some bloody mucus, and that is another sign of labor. We have the breaking of waters, that is the drainage of the liquor, the membranes rupture, and then the amniotic fluid flows out. And finally, we have the urge to go to the toilet. That happens because as the fetus is moving down the pelvic bones, then it is applying pressure on the rectum. And as it applies pressure on the rectum, then the woman feels an urge to go to the toilet. So those are the signs, the 4 signs of true labor, which every woman must be able to identify. And at that point, I will invite any questions throughout the discussion, and I'll be glad to take them. Thank you.
Yes, Linda, there's a question at the chat box. Someone is asking, is there anything like excessive vomiting in the first trimester?
Yes, it can happen, and it's an abnormality in the first trimester or whichever trimester of pregnancy. Normally, what is normal is the nausea because of the change in the hormones. But as I said, if it progresses to vomiting, then one needs care. Vomiting once in a while is okay, that can be manageable. But if you're in a situation where this woman is vomiting every other minute, then that means we have the depletion of fluid and the body minerals and electrolytes in her body, and she will need to be taken care of.
Okay, I have a question. I have a question on the second trimester where you said breast may to leak a little. So is it really milk, or it is just it is somehow fluid, watery? Is it really?
Not really. And actually, if you look at breast milk, haitakaa rangi ya maziwa ya like the cow milk that we take, it's usually lighter. And as it is forming initially, it will drain as maybe some fluid, some straw-like colored fluid. So whatever discharge we are having at that point, as long as it is not foul smelling, then we would take that as a preparation of the breasts to discharge milk.
Another question at the chat box. What can cause the fetus to stop developing, resulting into a miscarriage?
There are a number of factors that contribute to miscarriages, some which are unknown, but some of the ones that are known, number one would include an infection. If the woman has an infection that gets into the uterus, then it would lead to the death of the fetus, which would be definitely a miscarriage. Number two is maybe a fetal malformation. So maybe as the fetus was being formed, there was a mishap somewhere and some body organs did not form completely or well enough to form, like to make a baby out of it. And so definitely the body will try to eliminate that pregnancy.
I have a question. Is it true that some food spices can lead to a miscarriage?
I haven't heard of such a thing, like a food, I mean, a spice leading to a miscarriage. Not really. Or are they not the regular food spices that we use?
Yeah, the regular food spices. Okay. I had someone telling me of the experience. They had turmeric in their second trimester, and then they experienced some weird pains and like they were getting some forced labor, and it was quite early in the pregnancy, 5 months down the line. So she was experiencing some sort of a forced labor, and then like immediately after the pain, she had a lot of vomiting, which she thought is what helped with the situation.
I would say that is a myth, just as people say that if you take a lot of pineapples, then it quickens labor. You've heard of such a myth as well? So yeah. I don't think that is true. Maybe they are trying to attribute, to give a cause to the miscarriage, which is not scientifically true.
Okay.
Yeah.
Another question is, all through the semesters, what should be the sleeping position of the woman? And can the sleeping position affect the pregnancy?
The ideal position of sleeping for an expectant woman is the left, we call it the left lateral position, which means she sleeps on her left. And the reason for this is we have some blood vessels that run along the right side. And so when she sleeps on the right side of the back, the fetus applies pressure on those blood vessels. And number one, that will lead to a decreased return of blood back to the heart. So she will start having edema. The blood going back to the heart becomes less, and definitely the blood that is supposed to come from the heart and get supplied to other body organs becomes less. So we advise her to sleep on the left so that she avoids lying on those blood vessels, especially towards the end of the second trimester all the way to the third trimester when the fetus has really grown in size.
Someone is also asking, at what time should the husband stop having sex with his pregnant wife? And does sex during pregnancy important?
That will depend with a couple. There is no contraindication of sex in pregnancy as long as the woman is comfortable. So they can have sex up to the last day of delivery if the woman is comfortable. Maybe the only thing they can do is maybe try to adjust to different positions so that she's comfortable during the whole experience.
Someone is also asking what causes inflammation of the legs, especially the ankle area in the first trimester?
Now, when we have a fetus growing, you will rarely find edema. That inflammation is known as edema. You will rarely find edema during the first trimester. It mostly occurs as the fetus is growing for the same reason I have given us. When this fetus has grown, it compresses on blood vessels. And when it compresses on those blood vessels, they become smaller, such that enough blood is not able to pass through them. And so the blood that goes down to the legs does not have enough space to be taken back to the heart. So the blood accumulates in the legs, leading to edema. So now in the first trimester, unless she has other medical conditions that would lead to that, but I wouldn't really attribute that to the pregnancy.
I have a question still on the, you said an ultrasound can be detected during the second trimester. The ultrasound, does it really produce the real sex of the child? Like, okay, like I've heard in some cases they say ultrasound linadanganya, it's not true. Like inaweza kwambia you are expecting a female child whereas you have a male child. Like, is it really true?
What I can say about that is that it would depend on whoever is analyzing the ultrasound. Are they able to really tell which gender they are looking at? Are they able to understand the ultrasound itself? But if it changes along the way, that I don't know how that would happen if really someone checked it correctly.
Then how often is a pregnant mother supposed to do ultrasound? Like, is it once more?
Number one, it would depend on the needs of this woman. Maybe she's having some issues, maybe infections once in a while. She's reporting of maybe abdominal pains. She has at an instance had vaginal bleeding. And so those issues will cause us to want to do an ultrasound to monitor the pregnancy. In other cases, maybe she just wants to know the gender of the baby. Other times, probably towards the end of the pregnancy, you just want to know what's the size of this fetus so that we are able to predict and know if she can go through a normal delivery or not. So basically, depending on the personal needs of a certain client, there is no stipulated that lazima uende ultrasound mbili ama moja. It will depend with individuals.
Still on that, I'm sorry for being so insensitive. Then on the IFAS, they say nasikianga wakisema IFAS inanuka sijui kunguni, and then the more you take them, the more you have the urge of vomiting. So is there any alternative for IFAS, or it's just?
Now we have alternative supplements. We commonly know IFAS because it is what our government is able to provide to us at a very cheap price. And in most cases, it's actually given freely, but it has the side effect of causing nausea. So one thing we advise, if a woman is taking IFAS and she's experiencing nausea, then we advise them to take the IFAS with meals. Akikula food yake anakula pamoja na IFAS. If it persists, then she can change into other supplements which are more expensive. For example, I think we have the Pregnacare and other supplements. It's basically iron and folic acid supplement. So whichever brand that you're able to use, then that is what you use. It is also true it has a metallic taste for some people, which sometimes they are unable to tolerate. That is why when you at least take it with food, then you're not able to get that metallic taste remaining in your mouth.
Someone is also asking in the chat box, what happens in a mother's womb when there is pregnancy for almost 9 months, but at the end of it, it's not a baby, something not developed?
Now we have what we call a molar pregnancy. So for a molar pregnancy, we have fertilization taking place, but now instead of, there is the embryo sac, that sac that contains the fetus, it is formed, but inside it where the fetus is supposed to be, we do not have a fetus. I hope that makes sense. And so when that happens, it will continue enlarging, just as a normal pregnancy would enlarge. If you do a pregnancy test, it will test positive. But then the HCG levels, remember we talked about the HCG being produced in the first trimester. If you do a test of the HCG level, that is a blood test, you will have elevated HCG levels. There is normal HCG level of a normal pregnancy. But in case of a molar pregnancy, the HCG levels are elevated. And that is why these ultrasounds are very important. If you are able to do an ultrasound, probably in every trimester, then you're able to know exactly what is inside the uterus. And so if a person never does any ultrasound, they are not aware of any signs of a pregnancy. Now, for example, in a normal pregnancy in the second trimester, we've said she will experience the fetus making movements. Maybe this person is not aware they're supposed to experience any fetal movements. For a person who is aware of that, pregnancy will progress and they get concerned. Probably 7 months, I'm not getting any fetal movements. So they are able to inquire, but it happens. Though rarely does it get to 9 months, the body will automatically just reject it.
Then maybe I didn't get this clearly on the issue of a pregnant mother having sex. Is there a certain time that a pregnant mother should just stop having sex at all?
No, unless she's not comfortable, or in some cases maybe of a missed miscarriage. She was almost having a miscarriage and it didn't happen, then sometimes they are advised to take rest. But in normal circumstances, as I said, they can have sex even to the day of delivery, as long as they are comfortable.
There was a question I also asked, maybe you didn't see it in the chat box, like what really causes a miscarriage? Like what really brings about the miscarriage of a pregnant mother?
Okay, I think someone else asked the same question and they said, we have some causes of miscarriages that are not known, and we have a few, very few that are known. And one of the known ones is an infection. So when a woman has an infection, maybe a UTI that is not treated, maybe an STI, gonorrhea, the syphilis, and all those, they end up getting into the fetus. Remember, where we are having these infections is the birth canal. And so when they get up and infect the uterus, the fetus inside the uterus, then we will have almost an automatic death of the fetus. And the body will definitely get rid of that fetus. The others could be maybe a malformation of the baby. The baby, when the fetus was being formed, there were problems with the formation. Maybe a body organ wasn't formed, or we had issues with the chromosomes, and the body will detect that and automatically get rid of that fetus. Other things would be maybe trauma to the woman. Maybe she had a fall, the uterus was injured, maybe she has an incompetent cervix. You've heard of people who have to be stitched at the cervix to allow a pregnancy to be retained. So if the cervix is incompetent, which means the cervix cannot close up to allow the contents in the uterus to grow, then each time she gets a pregnancy, the cervix opens and gives way, and then we have a miscarriage happening. Those are just some of the known causes, but then we could have very
I think I've lost the speaker.
sorry, I think I was kicked out of Zoom. So I was talking about the rhesus incompatibility. And so I was saying, when we have a woman who is rhesus negative and the fetus is rhesus positive, the woman's body might fight the fetus as a foreign body, and that would lead to a miscarriage as well. Any other questions? You can raise your hand and speak to us. Teresa's hand is up.
I have two questions.
Mm-hmm.
My first question is, when do we say that a pregnancy is term, like in terms of weeks? Like, is it 37 weeks, 40 weeks? Okay, yeah. And then my second question is, when mothers do come for their ANC visits, like, are they taken through this the way you've explained it to us? Like, the mother is in the first trimester. Do you tell them that this and this and this is what is happening to you and the fetus? The second trimester, this and this and this is what's happening. And the third one, like, are they educated about these things in the hospital setting, like in reality?
Ideally, that is what's supposed to happen. Every woman has a right to proper maternal education. And basically the reason we are here so that we are all empowered. If you're working in a healthcare facility or you go to a healthcare facility, then you deserve to be given all this information. That is the ideal. But now whatever happens on the ground is sometimes quite different, though you will sometimes find people who have the time to walk you through, and it becomes very important for this woman. She gets the knowledge and the skills. The first question was?
Like the normal duration for pregnancy, like when we say pregnancy is in term.
Okay.
Yeah, so what's the proper week?
It differs with countries. In our country, our term, at a pregnancy that we can call a viable pregnancy, which is if a fetus is born at that time, it can live, is 24 weeks. That is in our country. In other countries where they have advanced machines to support a fetus, even in the early second trimester, then they have an earlier viability. But for term will be any time around 36 to 40 weeks when a fetus will be born. Though if it is born anytime from 24 weeks, then we have chances of survival of that fetus. Is that well answered, Teresa?
Yes, thank you.
Welcome. Rose's hand is up.
Good evening.
Good evening.
Yeah, my question is, here is a mother. She has completed the 7 weeks well, she didn't have problems, but now after during a birth, she pushes a well bouncing baby. Then after 3 hours, she dies. What is the cause of her death?
Causes would be different. Number one, how was the nature of the birth? Was it a prolonged birth? If she was doing a normal labor, or even if she went for a cesarean section, what was the care given up to that point? Did the woman develop any complications at labor? Which happens? Maybe what they say, mtoto alichoka kwa tumbo, when they pass poop inside the uterus, the meconium aspiration for those who are medical professionals, and we have the fetus inside the womb aspirating, anakunywa hiyo uchafu yenye ametoa, and that congests their lungs. So when they are born, then they are not able to make adequate breaths. Remember, immediately they are born, they are now depending on themselves. Unlike in the uterus where they were dependent on the placenta, immediately they are outside, their lungs must be efficient enough to make breaths for this baby. So if they had ingested the meconium, the lungs are full with that fluid, then they are not able to sustain their breathing. And unless that is identified and corrected early, then we will have the fetus, we are likely lose that that baby. Again, maybe we had injuries during the birth process. The baby got traumatized as they were being born, and crucial centers or vital organs were injured during the process. That would also lead to the death of a baby. Probably an infection that began while the baby was still inside the uterus. There could be a number of reasons that surround all the duration from the conception of that baby.
Excuse me, I was talking about the mother dying.
The death of the mother?
Yes.
Sorry, I got the death of the baby. There are factors that lead to maternal deaths.
Yes.
Number one is what we call postpartum hemorrhage. So the woman bleeds excessively during birth, and that of course takes down their blood level. And remember now, the blood in the body is the one that supplies all the vital organs that would lead to death. Number two is if we have maybe an emboli. An emboli is maybe the amniotic fluid or air getting into the blood vessels, and that blocks how they are able to breathe. That is another cause of maternal death. A third one may be an infection, which will maybe later happen after pregnancy has occurred. But in our setup, the major cause of maternal mortality is postpartum hemorrhage.
Okay. Thank you.
Welcome. Anna Kipsiwa.
Hi, my question is, I want to ask there is a woman who is rhesus negative. Then in her first pregnancy, the first child survives. Then in the other subsequent pregnancy, those children cannot survive. What causes this?
I would want to know if she was given a drug we call anti-D after the delivery of the first baby. Was that done?
I don't know. It's just the story which I had. Now I cannot detect.
So we have the anti-D that is given, and this one is a drug just to make sure that the maternal body does not reject a future pregnancy that is probably a rhesus negative pregnancy. So when the anti-D is given, then we have the securing of future pregnancies. But if not, then the body will continue recognizing a rhesus negative fetus as a foreigner in its body and will keep flushing them out.
Oh, what about that the first child?
The first child survived, yes.
Why?
It's possible because the woman's body ni kama haikuwa bado identify that as something that is foreign to its body.
Thanks.
You're welcome.
Well, I don't know if maybe this is
So
just
still, excuse me.
true. Like there are certain foods a pregnant mother is not supposed to eat while pregnant. Like I think maybe there are meats or something. Like when you eat eggs, the baby comes out with the the baby will won't be having hair. Yeah, zinatakuwa na nywele ile moja moja ile akikula mayai mingi. Yeah, they're just certain foods. So is it true like certain foods a mother is supposed to avoid for the formation of?
Not at all. Those are just myths. She only avoids what makes her uncomfortable during pregnancy. For example, we said if she's having heartburn, then you advise her to avoid acidic foods. If maybe she's getting, like when she feeds on certain foods, she gets nauseated, that is what she avoids. But there's no specific food that she shouldn't eat. We advise them to take a balanced diet, and remember we said they stop the bad habits. So if they were using anything that is not normal food, I mean, if they were abusing any drug, then that is what they need to stop. But particularly to food, there is nothing that is not, I mean, there's nothing that they can't take in particular. Hiyo ya mayai is a myth.
Yes. Still on the blood resource.
Yes.
Now, if there is a couple with that problem, is it good they divorce, or how do they go about it?
With the rhesus problem,
Yeah.
What we normally advise them to do is to make sure that the anti-D has been given the way it's supposed to be done. There is a dose that is given during pregnancy and another dose is given at birth. That protects the future pregnancies. So they don't divorce, it's something that is manageable.
Okay.
Yeah.
Then how do we get these albinos?
Like I can see someone saying in the chat box, it's hereditary.
Okay.
Yeah, so sometimes we have a mismatch of the chromosomes that are responsible for the formation of the skin color. And when that happens, then the skin color, that is the melanin, the melanocytes that form melanin, which gives us our black color, is not well formed in them.
Okay.
Yeah.
Thank you. Thank you.
We have Nathan, your hand has been up for a while. Nathan, please ask your question. Ann Kipsiwa.
I'd already said the question.
Okay. Our moderator, kindly, is there any question I haven't answered on the chat box?
I have a question. Yeah, at what point do we detect or identify that a mother has a high risk pregnancy?
It can be at any stage of the pregnancy, and that is why we have discussed the various danger signs. If, for example, this woman comes with vaginal bleeding in the first trimester, then she's diagnosed with what we call a missed miscarriage, a missed abortion, sorry to say. So that is a high risk pregnancy because we are trying to contain this pregnancy as much as we can. Then in the third trimester, maybe they start presenting with issues of high blood pressure, that becomes a high-risk pregnancy at that time. Maybe they have a pre-existing condition. This is a woman who has gotten pregnant, but they have been on medication, on hypertensive medication all along, maybe diabetic medication, maybe a convulsive disorder, then that becomes a high-risk pregnancy. So it doesn't matter, but as long as the life of this woman is being endangered further by the pregnancy, then she becomes a high-risk, she has a high-risk pregnancy.
I have a question, and I think I've seen it in the chat box. Like, there are these women that just come to the hospital, like they say they are feeling pain. So all this while throughout the 3 trimesters, they have heard of nothing. They didn't attend the antenatal clinics. They didn't, like, the mother wasn't aware that she's pregnant, and then she just hospital, she's having labor pains, and then she's told you're having a baby. Is it really?
I doubt that if that is true. You can't miss out on the changes that are happening in your body. Anyone would want to know, why is my abdomen getting larger? Why am I feeling things kicking inside? So I doubt if a woman will carry a pregnancy up to term and they don't know they were expectant. Any other question?
Yes, I still have a question. You see there are these women hawa wa kuzalisha hawa. Like wanasemanga eti at sometimes mtoto amelala vibaya, mtoto amelala in a position which is not good, and in the process they tell you for you be coming so that wanaweza tengeneza mtoto. So in the process, like they are massaging the abdomen, ati wanasema they are turning the baby. Like, is it really?
We stopped doing that. It is no longer right to do that. Okay, Kitambo, they used to try and manipulate the lie of the baby through the abdomen. Maybe if the baby was seated, they want to try and turn the head down, and they would do various maneuvers, which with research and the various complications that were coming along those women, then that was contraindicated. We no longer do the reversion. If the baby has not turned by the time you're having the delivery, then a CS needs to be done. We don't do the reversion, the aversion anymore.
Okay, thank you for that.
Nathan is asking, what do we say is a stillbirth and what causes it? A stillbirth is when we had a very normal fetus. The woman went into labor when the fetal heart rate was very loud. It was regular, it was okay. But during the process of labor, we lost the fetus. So by the time the labor process is getting to a closure, the time we are having this fetus, then we already have a dead fetus. And one of the reasons is maybe a prolonged labor. Remember, when we are having labor, we will have limited supply of blood and oxygen to the fetus. As labor is taking place, the placenta is not able to sufficiently supply the fetus with the nutrients that it requires, and especially oxygen. And so if this labor continues for long, then we have the death of the fetus. That is one of the major reasons. And the causes of prolonged labor are many, ranging from maybe an inadequate pelvis, inadequate maternal efforts. They could range from a big baby and such issues, but that is one of the causes, of the main causes of a stillbirth. Now, the next question is on prolonged labor pains. We have 5 factors that contribute to how labor progresses. Number 1, we actually call them the 5 Ps. The first one is the passenger. The passenger is the fetus. what are the characteristics of this fetus that are facilitating the delivery process. If, for example, we have a fetus who is larger than the maternal pelvis, then definitely the pelvis is not adequate for this fetus. Number two, we have the passage. The passage is the maternal pelvis. Is the pelvis adequate enough for this fetus to pass through? So if the maternal pelvis is not adequate enough, then the fetus is not able to pass through. And then we have the psyche, that is the third P. The psyche is the maternal efforts. Is she able to push? Does she have the energy to participate in the labor process? As she's having a contraction, is she able to bear down and push out the fetus? The next one is the placenta. Is the placenta still attached? Is it still able to supply the fetus with the nutrients that it requires and sustain the labor process? And then the final P is, it's skipping off my mind. Yeah, those were 4. I remember the 5th one, but those are the factors that contribute to a prolonged labor. So if any of those factors is not in place, then the labor gets prolonged and it becomes very detrimental to the health of the fetus.
How about an experienced nurse?
Unexperienced.
Yeah.
Yeah, sometimes if she's not skilled enough to be able to assist the woman in labor, then mtaka tu amemwangalia. And some of the things, you see, now labor is a natural process. You've heard of people who have given birth along streets. So it is very natural, and the skilled personnel is there just to assist in the labor process. In case of any difficulties, they assist, maybe to prevent things like tears by supporting the woman and such things. So if maybe we are having a problem, maybe this baby has presented in the wrong way, and whoever is assisting in the delivery is not skilled enough to know how to support maybe a breech delivery. How do we handle a prolonged labor? If we have had the fetus aspirating the meconium, then how are we able to assist this woman? Then that would also lead to a poor outcome for both the mother and the baby. Someone is talking about the presence of fibroids causing stillbirth. If it was a very large fibroid, then it causes what we call intrauterine fetal death, or the fetus is not able to grow adequately. A fibroid is a growth that occurs in the uterus. So when it occurs, it reduces the space that the fetus needs to occupy for it to grow. And so with that happening, we are unlikely to get this pregnancy to term. But about stillbirths, very rare. If the fetus was able to grow na fibroid bado ilikuwa, then it's unlikely to hinder the delivery of that fetus, unless the fibroid was along the opening or along the birth canal. And now when we are doing the ultrasounds, which are very important, then we are able to identify vitu kama fibroids, and then we plan for care appropriately. Is there any other question?
Yes, is it true that the size of the pelvis can be determined by the size of shoe that a woman puts on?
Yeah, that definitely tells you if you have a short foot, it's a clear indication that your bones are short, isn't it? So that simply tells us your pelvis could not always, but is most likely not adequate.
I want to ask,
Mm-hmm.
yes, I want to ask, what about those those women whom they give birth to children whom they are not real. Like the head is for the dog, the legs for woman, the other parts are different. What brings about this?
That happens when we have a chromosomal malformations or chromosomal deformities. When we talked about the cells dividing, after the sperm and the ovum fused, we have the division of the cells. So when that is happening, there's a lot of interchanging between the maternal and the paternal chromosomes. And so sometimes when we have a mismatch, then we are likely to have some body organ not being formed completely. Another cause is what we call the teratogens, which are, what do I call them? Dangerous agents. For example, maybe the x-rays, the woman used some drugs that affected the formation of those body organs, and the teratogens will also lead to the malformations of a fetus. What causes children to be born with disability and how it can be prevented? We've talked about how the disabilities occur. One way of preventing that is ensuring that the woman does not take any harmful substances, especially during the first trimester. We said that they should not self-medicate because some of those drugs that are in our chemists and pharmacies are themselves teratogens. They avoid radiations. And now we also do the frequent maybe do ultrasounds once in a while and check on how the fetus is. Sometimes if you are high risk, you can do what we call genetic counseling. But then for other issues, like for example, the mismatch in the chromosomes, then that we cannot prevent.
Yes, I want to ask what brings about the fibroids? What causes those people who are affected by fibroids? What causes them to
causes
form?
Fibroids?
Yes, yes.
The cause of fibroids is not clearly known, but we have some predisposing factors, like things that can make a woman more at a higher risk of developing the fibroids. Number one is late conception. If a woman conceives very late in her age, then that gives room for the fibroids to develop in the uterus. Causes, not so clear.
Okay.
Yeah. You can allow me to hand over the session back to the moderator. I have really enjoyed being here with you. And I thank you all for being here. I hope you have learned from the session. It's been really enjoyable. If you'd want to reach out to me, my email address is naslinda254@gmail.com, and I'll be happy to be of help to any one of you. Otherwise, thank you all for being here and have a lovely night.
Yeah, thank you, Linda. We are happy to learn more on the pre-stages, the layout, especially on the to-do lists, maternal changes, and danger signs. On behalf of everyone on the cohorts, we thank you for your insights tonight. I'm sure everyone now has some knowledge and understanding of the week-by-week pregnancies. And once again, thank you, and please accept our gifts of thanks on behalf of everyone. Thank you, Nurse Linda. To all our participants, we appreciate your involvement and thank you for sparing your valuable time for the session. We are sure that by participating in the session, you have gained useful knowledge and also new ideas. We would also like to share your valuable feedback with us for future planning and such sessions. Thank you once again, all of you, and good night. We can leave at our free time.
Thank you, guys.